Hello and welcome to this session on care worker well-being. I'm Rob Anderson and I'll be acting today as both chair and discussant during the session. I'll introduce our speakers shortly. Just to say that I'm currently the chair of the advisory board for the Sustainable Care Research Programme coordinated at the University of Sheffield, and also chair of the Research and Policy Committee of Family Carers Ireland. I was chair of the Eurocarers for 4 years, but most of my professional life has been as a research manager at the European Foundation for the Improvement of Living and Working Conditions, which is an EU agency based here in Dublin, in Ireland. And there I led a program of research that concentrated on issues like family care, health promotion, the aging workforce, and public services. I'd like to orient and introduce this session with a fairly quick reference to a late 2020 publication from the European Foundation, which takes up the issue of the long-term workforce, its employment and working conditions. And I think it's important in a session on care workers that we share a similar understanding of who are care workers and what they do. And I appreciate the conventional OECD approach to say that care workers are those who are providing either instrumental activities, support to dependent or disabled people, or personal ADL type support, bathing, washing, and so forth. They're doing this predominantly, at least in Europe, in the person's home, although they are also care workers in residential and community settings. And usually we think of care workers being employed, but not all are employees. Some are paid directly by families. And of course, there's also a very large number of unpaid care workers, the family carers. And the presentations today will speak to both employed care workers, such as home helps, but also about the situation of informal family carers. Coming from an EU background, just to point out that we do not have good data for the numbers and characteristics of care workers across the member states, and particularly we don't have very good data for the care workers who are involved with domestic care tasks, the instrumental activities of daily living. But we do know that there are very big differences in the numbers of care workers in the different member states. The most recent research to which I was referring suggests that at the moment across the EU, there are approximately 6.3 million people who are employed as care workers in the long-term care sector. But this number will be an underestimate because it doesn't count or consider care workers who are not formally registered. And it has to be seen in relation to the numbers of informal care workers, the families, friends and neighbours. These are estimated to be 44 million amongst those providing frequent informal care in the member states. As we all know, the majority of care workers, formal and informal, are women. The estimate is about 80% amongst the formal long-term care workforce. And I think it's important to note that the numbers of these workers over the age of 50 has been increasing in recent years. Many of them, about 2 in 5, are working part-time, and this is double the rate for the EU workforce as a whole. If we look at the job quality of care workers, which is a central theme for us here, where we're looking towards those sustainable arrangements with well-being outcomes, we find that most care workers formerly employed are satisfied with their work and enjoy the tasks that they do. However, only 22% are very satisfied with their working conditions, fewer than in the general workforce. Altogether, from the European Working Conditions surveys, we find that 7 in every 10 long-term care workers feel that they are doing something useful, which is higher than the proportions in general in healthcare or in the workforce as a whole. However, their working conditions, as we all know, are often difficult, arduous, and involve heavy lifting and other stressful work tasks. The report that I'm referring to also points out that many care workers experience adverse social behavior, humiliation, threats, verbal abuse, more often than healthcare and other workers, and that large sections suffer with mental health issues. Finally, we're all aware that the long-term care workforce in Europe is not the best paid, and a majority are paid well below the national average wages. This is particularly the case for the home help and domestic long-term care workers. That sets the scene, I hope, a little bit. There are other issues around the working conditions, the job prospects, career, the training of care workers, which I hope we'll be taking up in the discussion. But now I think it would be useful to have the two main presentations in this session. The first of which is coming from Hareth Al-Janabi from the University of Birmingham, where he is a professor of health economics, and he'll be talking to the theme of the costs and benefits of healthcare delivery for carer well-being in the UK. Thank you, Hareth.
Thank you for having me. As Rob was saying, I'm based at the University of Birmingham, where I have a programme of research around the measurement and valuation of the impacts of health and social care interventions on family carers' lives. And it's going to be this theme that I'm going to talk about in this presentation. The work's going to draw on an NIHR, National Institute for Health Research Career Development Fellowship that I held for 4 years. And I'm going to particularly talk about 2 studies related to the costs and benefits of healthcare delivery for carer wellbeing that we conducted as part of that fellowship. The work was done in collaboration with Carol McLoughlin, Mel Calvert, Nikos, Efstathiou, and Jan Oyebode. Next slide, please. So I'm a health economist, and a lot of work that health economists do is economic evaluation, looking at the costs and benefits of new interventions in the healthcare system, new organisational changes, ways of delivering services. So it might be things like introducing a new drug, a new respite care system, or changing the way patients are discharged from hospital, looking at early discharge, and looking at those in terms of their costs and their benefits to make a judgment about whether the particular policy change offers value for money. And a traditional focus of our work has been on the impact of these interventions on patients' health outcomes and costs to the healthcare system. But we increasingly know that there's a huge amount of unpaid family care in the UK and other countries, as Rob mentioned when he was setting the scene. The last census, we know that there are around 6.5 million unpaid family carers in the UK. And these family carers are likely to be heavily impacted and influenced by the way in which health and social care interventions are delivered to patients in the UK. And these costs and benefits of healthcare delivery for family carers' well-beings, what we're terming carer effects, have interested researchers, but haven't been regularly measured and valued within the health economic evaluations that often inform government funding decisions. Now, failure to do that means that we're first of all not capturing the full benefit often of a new intervention, but also that health and social care delivery can't properly reflect what's in the best interests of family carers as well as the patients that they look after. And we were particularly interested in studying two questions related to this in this aspect of the research. First of all, what are the mechanisms by which health and social care interventions for patients can have a knock-on impact on family carers' lives? And secondly, what types of interventions are likely to impact on family carers' well-being, and what sort of outcomes might they have for those family carers? And we investigated the first aspect, the mechanisms, through a qualitative study, and the second through a Delphi study. Next slide, please. So the qualitative work was published in 2019 in Social Science and Medicine. We've got the reference, or the front of the paper there. You might want to enlarge it just so we can see there. Yeah, thank you. And the aim of this work was to determine the mechanisms by which health and social care interventions impacted on family carers' lives. And we used focus groups and interviews with a purposeful sample of family carers and care professionals. And so we were interested in talking to family carers and care professionals across three clinical areas: stroke, dementia, and mental health. Three areas where there might be a significant family caring role for the patients, but also three areas where there were different challenges for family carers. And a lot of the work that we did was trying to work with people in those interviews and focus groups to link interventions for patients with potential impacts on the family carers' well-being, and talking through the sorts of reasons and pathways by which those impacts might occur. And we've got an example there at the bottom right-hand corner of the slide from a flip chart where the focus group participants were putting cards with interventions onto different sort of domains of the family carer's quality of life. The qualitative data from the interviews and focus groups were then analysed through descriptive and analytic accounts to develop an understanding of the core mechanisms by which services impacted on family carers' well-being. Next slide, please. We spoke to, the sample was fairly evenly split between care professionals and family carers, and we had reasonable numbers in each of the three clinical areas: stroke, mental health, and dementia. You can see we spoke to 49 participants in the qualitative phase, and people in different care professional roles: doctors, nurses, occupational and physiotherapists, psychologists, social workers, charity workers, and so forth, and family carers that were caring for a parent, a spouse, adult children, and in one case, another individual. Next slide, please. And through the detailed qualitative work, we developed 6 core mechanisms to explain the costs and benefits to family carers' well-being from health and social care delivery. And these core mechanisms were relevant across the 3 clinical conditions and also were prominent in the accounts of both care professionals and family carers. We had information, so information alongside the delivery of services was an important positive and negative influence on the experiences and well-being of family carers. Management of the care, so responsibility for managing patient care was shifted back and forth between formal services and the family care sector, and this had positive and negative impacts on family carers' lives. Patient outcomes, so many services, particularly things like medication and psychological intervention, were used to treat or stabilise patients' health conditions, and this often had a knock-on impact on those family carers close to the patient. Alienation, so service delivery could foster feelings of alienation amongst family carers or potentially include them in care delivery. Compliance, so patients' compliance and engagement with services was needed in order for the service to benefit the lives of patients and family carers. And finally, timing and location. Family carers were affected by decisions relating positively and negatively affected by decisions relating to the timing and location of services for patients. And the initial letter of each of those 6 mechanisms spells out the word impact. So this is a mnemonic that could be potentially used to help people remember the positive and negative impact health and social care delivery can have on family carers' lives. Next slide, please. Got a couple of quotes there from the qualitative work, so relating to the mechanism around information. So we've got a quote there about the positive impact of information on family carers' lives from a woman caring for her husband after a stroke. It could be anything: exercises to improve swallowing, exercises to improve the movement. It was really good. It left you with something that you could do yourself as well, and you felt involved in it. So positive impacts there on the well-being of the carer. Whereas we've got a mother who cared for her adult son with mental health problems, saying you only get one or two individuals who are saying it's going to be okay. He's taking his medication, and then you get another individual saying, we can't tell you that is confidential. How can you have that imbalance? So there were barriers to information getting to the family carer about the care pathway for her son, and that had a very negative impact on her well-being. Next slide, please. So these 6 core mechanisms resulted in some cases in benefits to carers and in some cases harms to carers' well-being. So the first mechanism there, information, there were benefits to carers' well-being when service delivery was associated with advice, supporting the carer to adapt to their situation, promoting feelings of competence and peace of mind. But a tendency for service delivery to harm the carer when carers were left unprepared, had a poor understanding of the prognosis of the patient, were left confused or overwhelmed. Management of the care service delivery had a positive impact generally on family carers, where when there were shifts of care from the home setting to formal care settings, when this was the preference of the family, when services offered temporary relief to family carers, and when services substituted tasks that family carers were engaged in. But negative impacts on carers' well-being when there were rapid transfers of responsibility to the family, additional tasks that they were required to do, and they had to provide additional financial input into care. Patient outcomes tended to benefit carers when they service delivery treated symptoms, stabilised conditions, built patients' skills, improved their mood and prevented decline. But there could be adverse impacts on carers when there were adverse effects from things like medication on the patient, or the patient became more independent, and that was a challenge for family carers. And as you can see, the other mechanisms, alienation, compliance, and timing and location, are also associated with features of service delivery that resulted in benefit to carers on the left-hand side, or harms to carers on the right-hand side. Next slide, please. And we put all these 6 mechanisms or pathways by which delivery of health and social care services for patients could impact on carers' wellbeing into this framework. And you can see, maybe if you enlarge this slide, we can see that the 2 mechanisms on the right-hand side there, compliance and patient condition, relate to how the patient responds to the health and social care intervention. But there are 4 other pathways on the left-hand side by which health and social care delivery for patients can have a more direct impact on carers' well-being. And there are positive impacts and negative impacts there in red. And that figure is replicated in the paper if you want to look it up. Next slide, please. So the second related study was looking at when these carer effects were likely to occur and whether they should be formally considered in decision making. And we used an online Delphi survey over 2 rounds with 65 UK-based expert participants. So we drew on 49 participants from the qualitative research conducted in the first study, and also included a group of senior researchers that had expertise in interventional research in those 3 clinical areas: stroke, dementia, and mental health. And our focus was on looking at the impact of what we termed interventions, health and social care interventions, and organisational changes in health and social care. And the participants in the Delphi survey assessed the likely impacts that these interventions and organisational changes would have on family carers' lives, and thought about whether these carer effects should be formally considered in decision making about the delivery of services. Next slide, please. And we've got a summary of the findings here, so perhaps if we enlarge this one. So the graphs here show the perceived impacts across 5 domains of the carers' lives. Their emotional health on the left, physical health, for example, things like fatigue, sleep and pain, their finances, perceived impact on their ability to do paid work, and perceived impacts on their free time. And these are all issues that should, in theory, be considered in the value for money assessments of healthcare interventions. And we can see when it came to patient treatment interventions, most of the participants tended to think that on balance, things that were treating the patient's outcomes would have a positive knock-on impact on the carer. So you can see the green bars are generally higher than the red bars in that top graph. So a perception that on balance, they would have positive impacts. In the second graph at the bottom there, for replacement care interventions, there was a much stronger feeling that when you had things like respite care and interventions to relieve the family carer of aspects of their caring role, these would have a really significant positive impact on the carer's life. And you can see those high green bars for emotional health, positive impacts on the carer's physical health, ability to do paid work and free time. And the area of their life where they thought the impacts were much more likely to be mixed was on their finances, presumably because a lot of family carers would have to contribute towards the cost of the replacement care intervention. Next slide. So in this third graph, we were looking at organisational, in the third and fourth graphs, we're looking at organisational changes. And firstly, changes to the timing or location of the health and social care intervention. And here we can see a more mixed impact. Generally, these organisational changes were perceived to have mixed impacts and, on balance, more negative impacts on different aspects of the carer's life and well-being, with those red bars generally being slightly higher than the green bars. And then when we come to the final type of organisational change, changes to staffing, we can see that very few participants in a Delphi survey thought it was likely that on balance staffing changes had positive impacts on carers' well-being across any of those 5 domains. And you can see that the red and the amber bars are much higher than the green bars, but also that staffing changes might be the one area of organisational change that were likely not to have a particular impact on family carers. You can see the grey bars are higher than for other interventions. Next slide, please. The final aspect we looked at was including carer effects in decision making. And here we were looking at 3 types of decision that you might want to consider these knock-on impacts on carers. Research decisions around whether to collect data on the impact of interventions on carers, family carers, as well as patients. Funding decisions, decisions about whether to formally fund and provide these services at a national and local level, and individual care decisions, so decisions about the treatment that individual patients were getting. And we can see across all those 3 types of decision and all 3 clinical areas, there was a strong level of consensus that it was important to consider carer impacts in those decisions, in research decisions, in funding decisions, and individual care decisions, and particularly strongly in dementia and mental health. Next slide, please. So in conclusion, we can see that there are a very wide range of costs and benefits of health and social care interventions for carers' well-being, but we can potentially relate these to a core set of 6 mechanisms. Those 6 mechanisms can be summarised by the mnemonic impact, and these set of 6 mechanisms might be useful as a screen for researchers to identify, if they have a new study, whether it's important to consider collecting data and considering the impact of the intervention on family carers, so whether one of those 6 mechanisms is relevant. The mechanisms might also be useful in service design in health and social care to preempt negative impacts on carers by designing interventions to optimise the well-being of the family carer as well as the patient in intervention delivery. We found that carer effects were perceived to generally be positive for intervention strategies, but negative for organisational changes where there was a change in the timing and location of an intervention or staffing level. And we found that there was generally widespread support for considering carer effects in decision making, but this raises the question of how best to take that forward, given the significant barriers to considering carer well-being in everyday decision making about patients. Next slide, please. So I've just got the acknowledgements there from this research project and details about the funding, and also the reference to the paper we published on the first study. The second study is currently under review. My contact details if you want to get in touch, but that's it from me. Thank you for listening.
Thank you very much, Hareth. You covered a lot of ground there with 2 studies in 15 minutes, and I've no doubt we'll want to ask a few more detailed questions, but later. For the moment, we're going to turn the perspective from the impact of health and social care delivery on informal carers to look at the role and contribution of care workers, principally, I believe, from the home health type background, and go with Petra to look at the challenges in formal elderly care in Sweden, particularly with regard to intimate care provision. And I look forward to hearing your contribution.
Thank you. Yes, my name is Petra Ahnlund and I'm a lecturer and researcher at the Department of Social Work in Umeå, Sweden. And today I will talk about a research project that I am involved in, which is called Intimate Care Work. And it has the aim to analyze experiences of the performance of intimate care in home care services, mostly for elderly care, as you said, both from the care worker perspective, but also for the care recipient's perspective. Actually, today I will only talk about the care worker's perspective, but the project at large. Can I have the next slide, please? It is a research project founded by the Calvert Family Foundation for Entrepreneurship. And if Calvert is a familiar name for you, he was the founder of IKEA, so they're not only selling furniture, they're also supporting retail of different kinds. The project leader is Professor Hildur Kalman, and my co-researchers are Katarina Andersson and Veronica Lövgren, and it was Veronica and I who was supposed to have come to Sheffield last year, presenting our preliminary results. There will be other opportunities for us to come to Sheffield and the university. So the next slide, please. So the background for our project is the fact that disability and the frailty put many people in need of help with intimate care in their homes. And that can be, for example, it can be help with, using the toilet, changing adult diapers, the incontinent pads, showering, washing intimate parts of the body, brushing teeth, shaving, etc., etc. There's a lot of aspects we're talking about. And being a cornerstone in home care services, where the challenge of dignity and integrity is at its extreme and becomes most evident, and where feelings of, for example, anxiety and embarrassments need to be managed, intimate care is still a neglected area of research when it comes to elderly care services. And in Sweden, we have embraced to a large extent the ideology of staying in one's homes for as long as possible, meaning that it's quite difficult to get a place in a nursing home when you are in need of care services. So people tend to stay in their homes for up in the old age. And also, the ideology of home care addresses highly autonomous and capable citizens, while the practice meets elderly care recipients who are increasingly frail and disabled. So next slide, please. So one of the care workers' tasks, or the organization task, to make sure that care recipients are treated by dignity and with integrity. And while legislation and guidelines emphasize participation and influence for care receivers for the elderly, earlier observational and theoretical studies suggest rather sort of objectification and distancing as an interaction strategy to safeguard care recipients' dignity and integrity. And further, intimate care, as care work at large, is surrounded by gender prejudice, presuppositions and idealizations, and also attitudes that differ significantly between lawmen and those who have had the experience of receiving or performing intimate care. So these gaps are important to explore, and that's what we're doing in this project. So next slide, please. So these gaps between legislation and research, and also between this prejudice, this idealization and first-hand experiences, are important to explore. Through person accounts, those who care for elderly in need of intimate care, and also the care workers, but also the vulnerable citizens in need of intimate care. So that's what we've been doing. So the aim of this presentation today is to present only then care workers' experience of providing intimate care in home help services. And I also here looking beyond what intimate care is or the definition is. So we will focus on care workers' strategy to handle intimate care. And just so we understand, you had the same understanding of what we're talking about, we asked also the questions, what was perceived as intimate care. And we have, in the research group, we have found three different themes as personal hygiene, personal sphere, and of intimacy. So, but that's another discussion, another article. So this is not what we're going to talk about today. Today we're going to talk about the focus on care workers' strategies to handle intimate care work. So next slide, please. Maybe you can make that a little bit bigger. Thanks. So this study is based on individual semi-structured interviews with care workers. And in the project at large, we also interviewed care workers working as personal assistants, but also then recipients of home care services and recipients of personal assistance. We have been in 3 larger cities in Sweden, and to get sort of a variation in the experiences of intimate care, we searched for variations according to organizations of home care services, both public and private providers, as well as to participants' gender, ethnicity, service, and also age was searched for. So when we were out visiting different care organizations, to find people to interview, to find people participating in our study, we were kind of keen of that no experience was too small, so to say. Even if you haven't been working for a long time, we were interested in the experience of care work and intimate care work. And also, as you can, care work in home care services in Sweden are also gendered. And we interviewed 9 women and 1 man in this study, working in home care services and elderly care services. So this study was also, of course, approved by the Regional Ethical Review Board in Sweden. So next, before I'm presenting our different themes that we have, I would just wanted to give you a view of different strategies that the care workers have talked about during our interviews. And since this is a work in progress, and I would have hoped to discuss all these themes together with you, all these issues and tasks. But I think it was sort of an interesting picture to get an overview of the different things that we have seen. Because it's interesting how the professionals, they're talking about the need of being flexible and having a repertoire of strategies, because they are they have the responsibility for the intimate care performed in the home care services. They have to be knowledgeable about the individual, and they have also to be generous with time, because time is something that is present in the home care services in Sweden all the time. And at the same time, not talking about the lack of time that they may have. So time as, is something that is present, it's a continuity, time as handling the impression of time as well, and also time as timing. And so if not given sufficient time, it will be a problematic situation for the care workers. We can come back to that later. So next slide, please. So what we did, we asked questions such as, it's always when you do semi-structured interviews, it's an ongoing conversation in the interview session. But we asked questions as, think of a situation where you're performing intimate care. So tell me what's going on, how are you doing, and what are you saying? So we sort of nailed it down to 4 different themes: informative strategies, distracting strategies, learning for colleagues and care recipients, and also create a relationship with care recipients. And next slide, please. Going into the first one, formative strategy. This is something that everyone we talked to, we interviewed, said that they did. Every one of the care workers said that they were always, telling the person, the care recipients that they had to care for, what's happening in the intimate situation, to conversate, to inform of the next step. For example, when in the washing procedure, being in the shower was sort of self-evident according to the staff. And we have many examples from the interviews here. So here's a few, and they say, well, I talk a lot when I do things, explains step by step. Well, today it's a little bit red. Shall we take some cream on or something? I'm talking to them a bit so that you establish a kind of conversation. And one of them said, well, the thing is, because you talk and someone knows what you intend to do, it becomes a simplification for them. And the third says, well, if they have dementia, perhaps one should tell even in more detail, otherwise they can feel that they are not really with you. Wow, now she's picking up a diaper, what's next? So they should be able to feel safe. So we should tell them about what we do. So this strategy could be called, talk, because that was a really important thing that the interview persons stressed for us. Next slide, please. Distracting strategies make them. This was also a very an important strategy that they talked a lot about. And distracting strategies was about when a carer didn't want to, for example, take part in the activity that was about to happen. Or a common example was not to take a shower. It was, it was time for a shower. It was something that was planned to happen, and it was something that maybe was a long time since it happened, because I really want to take a shower. So then they said, well, if she doesn't want to take a shower, then you don't say, come on, Anna, I want you to take a shower. Instead, you say, let's go to the bathroom in case you need to pee. So they sort of stress that, well, let's start with your feet. Let's go into the bathroom, and I can start with this warm water, and maybe it feels nice on your back, and so on. So they sort of had these different distracting strategies. And one said, people with dementia can become aggressive if they do not recognize a face. So you have to decide in a good way. Work a little to get to the shower. We're going to the bathroom to cut your nails, one might say. And another one said, well, I know she loves coffee, so I brew it. And I'm warming up a cinnamon bun. It smells good. And then she remembers and whets her appetite. And sometimes I call her son to say that he has to tell her that she needs to wash. And it works sometimes. So calling a son so that he can say, well, mommy, you have to go into the shower now. It could also be a sort of a distracting strategy. So you have to find your way. Next slide, please. The third, learn from others, reflective strategies and working together. And if talk was it that everyone we interviewed were agreeing upon or used, this one was not really obvious for everyone, for most people, but not for everyone. And some stated the importance to communicate with colleagues, family, and of course, the care recipients also. But on the other hand, people say that it can be a very lonely task, and that you not always have someone to discuss these issues with. And one care worker said, well, this with showering, no one got him into the shower. And then I heard that someone had helped another man to shower with his underwear on. So I embraced that, and it worked. And someone said that find out how your care recipient wants to have it in the bathroom, and then they are, and then they can clean themselves. It is very individual and personal. So you have to learn. You have to build up a relationship, or you have to learn what that person wants. But talking to colleagues, talking to families sometimes, and also learn from the elderly themselves, of course. In balancing in relation to that, it could be a really lonely work, so it could be difficult. But this team is also about to participate in education or discussions group with colleagues. So it's about also organizing care work, I would say. And in Sweden, many home help services have something that is that one of the care workers have an extra responsibility for one of the elderly, or for one of the care recipients, so that they know about that person's wishes and how they want things and all that. So it's always a possibility also to contact this person who are in extra charge for someone if you need help, because helping when people, a common example is that people don't want to take a shower when it's time for it, and then you can work around it. How can we prepare this elderly person for this, and how can we work together so that it will be good for that person. So next slide, please. Yes, and the last one, creating relationship with care recipients, flexible rules and ingenuity. This was also an important strategy, of course, for being able to help with intimate care and also other caring tasks. And that was, of course, to create a good relationship with care recipients. And this was done in different ways. In the interviews, care workers talked about how they needed to be aware of boundaries, for example, and the other person's integrity, what they wanted to do, how they wanted things. But they also talked, of course, about being flexible and taking different rules. And for example, pretending to be from Mallorca, because the old men that you visit have been there, and since you are from a Spanish-speaking country, well, you can always pretend, that you are. Sorry, if you don't see that. So, what they say then? Well, you cannot just come home to someone and just, well, now it's time to take a shower. It may not work. It is this with continuity, getting to know each other and creating trust. One say, well, I have to work to earn money, so you have to let me shower you. Otherwise, I cannot go home to Mallorca. So they sort of build up a relationship where they know each other and that they can talk to each other in a certain way. And someone says, well, sometimes you just have to be religious. When someone is very religious, it has happened that they want to say a prayer together. Well, yes, of course I can. I can clasp my hands. You don't have to feel bad about that. So going into different rules and being flexible to create a relationship so that trust is at hand. And like a normal person with dementia, they quarrel aggressively and are grumpy. So sometimes they have no appetite. Then you have to invent, work and find out what that person loves the most. So next slide, please. The discussion. Well, one thing that we learned from this study is that even though care workers say that doing intimate care is something that they just do, it's part of the job, it is hard work. And it was clear that care workers had to find their own strategies to be able to preserve integrity and dignity for care recipients. Many of the care workers said that it was a topic seldom discussed, except when they faced a problematic situation, such as showering maybe. Because it's such a natural thing, taking care of your personal hygiene, it becomes almost an invisible task, even if that's what they are doing, care workers with the elderly. They're helping them with their personal hygiene. So seen in the light of sustainable care work and the well-being of care workers, it becomes important to organizing the care work in the home care services so that the care workers have the possibility to create a good relationship, so that they have time for reflection, both together with colleagues to make the intimate care as smooth, as pleasant as possible. Maybe talk to family and friends, maybe not their friends, family, next of kin, and organize the care work in that way. And in Sweden, we can see that the care work are not always organized in that way. But we also talked about time as an important factor. Sometimes it can be a really problematic thing about time. You have to do a lot of entrances in the home help services. You have to visit a lot of people, so maybe time can be something problematic. And also seen to earlier research that I thought is quick about in the beginning, strategies about that you have maybe objectification and distancing, and that's not really what we are experiencing in this study. It's more about being sort of close, getting close, so that you can create trust and preserve dignity and integrity. So it's important to have both time and opportunity to be professional in order to create care, so that care recipients have their dignity and integrity intact. So next slide, please. The last one. And thank you for your attention. And if you're interested in this subject, please contact us, because we are in the beginning of writing and analyzing. So we are lovely to have some more input. Well, thank you for listening.
Thank you, Petra. That was an interesting presentation on a really very important subject. And I have to acknowledge that the two different presentations are quite difficult to pack together and put under the heading of care and well-being. But I think that first of all is simply to acknowledge that we need to be aware of the number and diversity of workers or providers of care, both obviously from formal health, home help, social care services, and obviously also from the families. And I think that in both presentations, I reflected a couple of times that the provision of care is not either or in most cases. Sometimes families are doing it, sometimes formal care providers. Different times of day, different days of the week. And in thinking about the well-being of care workers, I think we should be quite explicit in considering the role and contribution of the different care workers and how they can be mutually supportive and, as we say in the conference, sustainable. Secondly, we are focusing here on carer well-being. And to some extent, I think both presentations were implicitly dealing with the well-being of both carers and recipients of care. But I wonder if there is anything you would like to say more explicitly about the concept of well-being as it applies to these different care workers. So can we think in the same terms about the well-being of the family carers that Hareth referred to and the well-being of the care providers, the home help assistants that Petra was talking about? Are the same dimensions to be considered? Obviously, health and physical and mental, material well-being and social relationships, they're probably a part of our panorama of themes that need to be considered. But would you give different weights to the importance of those different dimensions in the well-being of different categories or characters amongst those in the care workforce? And to go particularly to Hareth's presentation, he made reference to quality of life and research on quality of life underpinning many of the questions that were asked in the focus groups and the interviews. And my simple question to him, because I know he's been involved a lot as a health economist in measurement of well-being, is, are the terms well-being and quality of life more or less interchangeable? along the same lines, both presentations involved research with professional workers, professional providers in home help, home care, and other services, as well as family carers. In Petra's presentation, it seems to me she only presented results from the experiences of the care assistants and the paid care workers, but there were also interviews being done with the recipients of care, if I understood the slide correctly. With Hareth, it was quite clear that the work involved both professional care providers, not only in the home, as I understand it, but also in hospital and in the community, as well as family carers. This, I think, is very productive as a research strategy, but I heard nothing about the different perspectives of the formal care providers and the family carers, or in Petra's case, the perspectives of the social care assistants and the recipients or the families, if they were included. And I think that the one interesting perspective could be that the different providers and recipients and family carers have actually different points of view. I was also going to ask about the research selection of people to participate, the idea of the purposeful samples, but I think that Hareth, in fact, explained a lot of that. In the second part of Hareth's presentation, we looked at the views of, I think it was 65 people in the Delphi study. And I wondered there also if there was any difference in the views of the different providers, formal or family, about what was important. Secondly, I know there wasn't time for Hareth to go into all the detail of the second study, the Delphi study, but one or two things surprised me, at least on the surface. One was that organizational changes like staffing levels were perceived to have no impact on carer well-being, while on the other hand, there was a strong view that replacement care, which I understood to be illustrated as respite care, had a powerful positive impact on carer well-being. And again, the question there is, I think that the science, the literature on the role of respite care for family carers is quite equivocal in its results. And were you not surprised that there was a little more, that there was not more hesitation regarding the perceived value of replacement care? Finally, I appreciate that both presentations looked at some expected and unexpected outcomes of different interventions and strategies. They seem to share some common references to measures that let me just take two of those. One was participation of the care recipient, patient engagement, and the importance of that for successful management of intimate care, but also more generally for improved patient experience. And a little bit my question here is what can be done, or what is being done by formal care providers to encourage patient participation? And secondly, was the importance of communication. Communication between provider and recipients of services. Implicitly, I think, communication between providers and family carers. But also in Petra's presentation, I appreciated the reference to communication between different caregivers. The idea that the care workers were somehow giving each other hints or support or advice about how to manage intimate care better. And a few words came out from that, like promoting trust, like continuity of support. And I wonder if one or two other messages from your research also point in the direction of measures that potentially can improve the experience not only of care receivers, but also of the care providers, whether they are family or formal care workers. I'm going to leave it there for now and invite first Hareth and then Petra to pick up on one or more of the little comments that I've tried to make. So Hareth, if we could start with you.
Yeah, thanks, Rob. Some really interesting points, and I noted down some thoughts about a couple of those. So very happy to kick off. You raised that issue about well-being and quality of life, and I suppose in health economics, we're very focused on measuring health-related quality of life outcomes for patients. So typically focusing on things like the individual's mobility, anxiety and depression, pain and discomfort, and items like that. Whereas I think for carers, a broader concept of well-being is important because the caring role affects profoundly sort of other dimensions of their life related to things like relationships, fulfillment, control. So I sort of think of well-being as a broader concept, certainly than health-related quality of life, and something that would be a relevant sort of outcome for including carers within evaluations. I think the other issue I wanted to pick up on a bit was the point you raised about the different perspectives potentially between formal care workers and family carers, because as you highlighted, we had both in our study, and the aim of having both was to try and get at the sort of core understanding of how health and social care interventions impacted on family carers' lives, with care professionals being experts about the interventions and family carers being experts about the outcomes that they were having for their lives. And family carers did tend to emphasize the negative impacts of being excluded from decision making, from information not being available to them, from feeling sort of isolated, much more than care professionals did. And care professionals tended to emphasize the potential impact of treatments in freeing up the family carer to do more of what they might want to do in their lives. So family carers tended to have a slightly more negative perspective, I suppose, on how social care delivery might impact on their lives than paid care professionals did. But there was enough shared understanding and emphasis to come up with a core set of mechanisms, I think, to explain how those interventions impacted on family carers' lives, but the sort of emphasis did differ slightly between the two groups. Maybe I'll pass over to Petra to pick up on some of the themes as well that you.
Yes, thanks, and thank you, Rob, for superb. Yeah, well, I was thinking about, because we started the interviews to all these 4 groups that we've been interviewing, but especially health and care workers. So tell me about the good day at work. Why a good day at work? And the feeling of having been able to have been doing a good day is very important, and it consists of having time, having time for the small things, being able to maybe chit chat with your colleagues, and then every elderly are feeling fine with themselves. And so I think well-being and quality of life could be, of course, go hand in hand sometimes. But I also think that you've been interviewing both professionals and family carers, and seeing to professionals maybe have more higher up in the hierarchy. They have supervision. Social workers, since I'm working in a social work department, social workers, they have supervision with other qualified persons about how their work is doing. And that is one thing that I feel that care workers working in the elderly care sector, they don't have this supervision. They don't have the possibility to talk about what is being done and how should we be able to help the elderly. So it's sort of, there's a difference there as well. I think what we are supporting the care workers with, sort of both how to organize the care, but also what sort of support they get for actually entering another person's home and taking part of that person's everyday life. So that's also aspects of quality and wellness, I think. Yeah.
Yeah, you both emphasize the importance of information and communication. But Petra, when you talk about care workers not having the same kind of support from management, or didn't you emphasize the importance of the exchange between the care workers?
Yes. That's what we find so interesting, because they find ways, of course, to. It also depends on having a good management, and the staff that we interviewed, they were quite happy with their management, actually, because they said before it was this way and it was more stressful, but now that we have this management, we can actually have time for meeting together, coffee, and we have different 1-2 hours once a month that we actually can get together, and we get sort of discussion issues and questions that we can then discuss with each other. And then, of course, they are meeting, between going to their elderly, they are meeting and discussing and talking about these issues. So I think it's really, really important. I think it should be more formalized. That's why I'm stressing it right now.
Yeah, I referred back to the report that recently came from Eurofound that basically said that a lot of care workers get a lot of positive feelings in relation to their job. But what in your view might reinforce those positive feelings about work?
So those we talked to, those we interviewed, and also in other studies, they are happy with the work, as you say, they're quite happy, but they feel that the society doesn't always have such a good view on elderly care, on the elderly care services, which sort of spills over to the staff working in the elderly care sector. So they often feel that they have that sort of, when they say that they are working in the elderly care sector, people say that, oh, that must be so boring, and how is that? You don't have time for anything, and it's so hard, and you're not able to do a good work. But they have sort of that's also a barrier that they have to cross. So because they think it's a very nice, very giving work, and it's very interesting and fun, and they get a lot back, as you say. So yeah, the view from society could be something else than what they experience themselves, especially in these days with the COVID-19 and the pandemic. We have big discussions.
But did you have the same or some of the same sentiments, Hareth? I was wondering, we talk about this need to value carers more. It's always on the agenda. Of course, it's currently on the agenda because of COVID pandemic. And we need to be valuing not only the formal care providers, but also the family carers. Did you have any sense in your interviews or groups that the family carers felt undervalued?
Yeah. So I think there's always an element of this that's personal to the individual, that some people get a lot more fulfillment from their caring role than others. But I think there's also a lot about how well included the family member is in service provision, and that varied quite a lot. So particularly in mental health provision, a lot of family carers felt quite shut out and excluded, and part of that I think was around the sort of legislation and the interpretation of legislation by care professionals, that they weren't able to share information or didn't feel they could share information. And family members talked a lot about talking to different people, feeling quite shut out and excluded. But then there was a lot of positive feedback in relation to some of the other services. So with some of the stroke carers, the care professionals, particularly in the hospitals, were quite proactive in terms of explaining the likely prognosis for the patient and the role that the carer might have to play. And I got the sense that the carer sort of took that with them a little bit in their journey, and it gave them, it helped the caring role being more fulfilling because they felt more comfortable. They knew more about what to expect. They felt part of the care team for the patient and felt sort of valued. So I think it's that split between sort of there is that element that the formal care setting can influence in terms of how well included and valued that the family carer plays, but there's always going to be an element about that's sort of personal to the carer, that can't maybe be influenced by government policy or formal care organisations.
Yeah, I hope I'm not doing you an injustice, but it seemed as if the interventions that you were speaking about in the paper were largely being examined in terms of effects on carers as a byproduct of measures for patients. And if instead you were thinking about direct effects and what could be done to improve the well-being of the family carers, what do you think you would have said in addition?
So I think you're right. The starting point was, because 95% of what we end up evaluating are treatments for patients, the starting point was how can we consider the byproduct effects on carers. But I think the 6 mechanisms we identified give us a way of thinking proactively about the carer's well-being at the outset. And I think that it provides some lessons that if we are designing a service from scratch, we need to think about the information flow to family carers. We need to think about what tasks, as you said, are being done by the family member and what tasks are being done by the care professional, and how can we balance those two so there are good outcomes for both. We need to think about the degree to which there are peer networks for the family carer to learn off other family carers and not feel isolated in their caring role. And we need to think about things like where the services for patients are timed and located so that they fit in with the daily life of the carer as well as the patient. So I think there are a set of lessons about for the design of services with the carer's well-being in mind, rather than just thinking about them as a byproduct.
Okay, thank you. And sort of in conclusion, Petra's paper in particular talked about the population of people being cared for being increasingly frail and disabled, and you illustrate very well some of the really difficult care tasks that are undertaken both by families and by formal care providers. And I mentioned that as a kind of background to the concern that's often voiced about sustaining care by families or retaining workers to be able to support families in providing care. And my question is really, what do you think is most or could be most important as a measure to ensure that your home helps and care assistants want to remain providing the service that they do, rather than doing something else that's better paid or whatever? And also to Hareth, what do you think needs to be done to ensure that families are given, shall we say, the meaningful support to continue in these very difficult care tasks? Sustainable care. What does it mean in practice? It means more than, it means more than only our policymakers and politicians saying how important care is. It means something being done, I think, to support these workers, whether paid or unpaid. But from your point of view, is there something that steps out from your research or from your experience that really needs to be emphasized more?
Oh, if I can start, well, quite many of the persons that I met working in the elderly care sector as care workers, they have been working for a long time, and they do so because they have the opportunity to develop. They have the opportunity to get to know the persons that they're caring for, to being able to be professional in their work, get educated. They are auxiliary nurses or nursing assistants, and so to continue to be able to learn. I mean, they're meeting new persons, and every time you meet a new person, it's a new relationship that has to be established, and to get time to do that, to be able to be reflective in their work, and also to be able to be continuing to be educated. That's things that I come up with right now. Probably think of something else tomorrow, but some basic things.
That's really good to hear your real experience, that the idea that improving opportunities for professional development, career, job enhancement, these are really coming through on the ground. So thank you very much for that. Hareth?
Yeah, I think it's two parts to it. So I think firstly, carers have to be allowed to feel that their well-being is a legitimate concern. I think family carers have often given up their life to look after someone and are putting the patient first, and often feel that their needs have to be sort of suppressed. So I think an important part of sustaining the sort of caring network is carers are allowed to feel that their well-being is a legitimate concern. And then the second part to that is that there then has to be more formal mechanisms for taking into account what is good for the carer's well-being as well as the patient's well-being when designing a new service or treatment. some sort of formal way of considering the impact on the dyad, the carer and patient, as opposed to just the patient. So if you have an early discharge intervention that's going to suddenly land a family member with someone to look after with very little support, you try and avoid that situation. You preempt it by considering how you could optimize the situation for both.
Thank you. That makes so much sense, and particularly with regard to the patient groups you're referring to with stroke and mental health problems and dementia, who are being cared for 24/7 in many cases, with intervention from professional carers some of the time. So I appreciate your emphasis on thinking about both the recipients and their carers. And with that, I should say thank you very much for your contribution, and I hope you have enjoyed participating as much as I have, and I hope as the participants externally have done. Thank you now.
You, and thank you very much, Rob. You've been excellent summarizing. I mean, our two quite separate studies, but thank you very much.
It's my pleasure.
Thank you.
Thank you, Dan.